Good day, Swider Porsamporna is my name, and I am assigned to discuss with you all the anatomy and physiology, at the same time the pathophysiology of our case, breast carcinoma or cancer. The breast anatomy of males and females is slightly different. Female breasts have milk ducts and glandular tissue that aid breastfeeding. Male and female breast nipples have many nerves that enhance sexual arousal. All genders can get breast cancer. Women who are more prone to benign or non-cancerous breast diseases. But what exactly are our breasts? Breasts are part of the female and male sexual anatomy. For females, breasts are both functional for breastfeeding and sexual. On the other hand, male breasts don't have a function. As you can see in the photos below, the breast is an organ whose function reflects its special function, the production of milk for lactation or breastfeeding. The epithelial component of the tissue consists of lobules, where milk is made, which connect to ducts that lead out to the nipple. Most cancers of the breast arise from the cells which form the lobules and terminal ducts. These lobules and ducts are spread throughout the background fibrous tissue and adipose tissue or the fat that make up the majority of the breast. The male breast structure is nearly identical to the female breast, except that the male breast tissue lacks the specialized lobules since there is no physiologic need for milk production. Anatomically, the adult breast sits atop the pectoralis muscle or the pec chest muscle, which is atop the rib cage. The breast tissue extends horizontally or side to side from the edge of the sternum, which is the firm flat bone in the middle of the chest, out to the mid-axillary line, the center of the axilla or the underarm. A tail of breast tissue called the axillary tail of spans extend into the underarm area. This is important because a breast cancer can develop in the axillary tail even though it might not seem to be located within the actual breast. The breast tissue is encircled by a thin layer of connective tissue called the fascia. The deep layer of this fascia sits immediately atop the pectoralis muscle, and the superficial layer sits just under the skin. The skin covering the breast is similar to skin elsewhere on the body and has similar sweat glands, hair follicles, and other features. A clinician will examine the skin in addition to the breast tissue itself when performing a breast exam. Now for the blood supply and lymph nodes, the blood supply from the breast comes primarily from the internal mammary artery, which runs underneath the main breast tissue. The blood supply provides nutrients, such as oxygen, to the breast tissue. The lymphatic vessels of the breast flow into the opposite direction of the blood supply and drain into the lymph nodes. It is through these lymphatic vessels that breast cancers metastasize or spread to lymph nodes. Most lymphatic vessels flow to the axillary or underarm lymph nodes, while a smaller number of lymphatic vessels flow to internal mammary lymph nodes located deep to the breast. Knowledge of this lymphatic drainage is important because when a breast cancer metastasizes, it usually involves the first lymph node in the chain of lymph. This is called the sentinel lymph node, and a surgeon may remove this lymph node to check for metastasis in a patient with breast cancer. Many additional changes are seen in the breast tissue during pregnancy and lactation due to the changes in hormones during those times. The breasts are located between the second and sixth ribs over the pectoralis muscle from the sternum to the mid-axillary line. An area of breast tissue called the tail of spans extends into the axilla. Facial bands called Cooper's ligaments support the breast on the chest wall. The inframammary fold or crease is a ridge of fat at the bottom of the breast. Each breast contains 12 to 20 cone-shaped lobes, which are made up of glandular elements, these are the lobules and ducts, and are separated by fat and fibrous tissue that binds the lobes together. Milk is produced in the lobules and then carried through the ducts to the nipple. In this figure 48.1, you can see the anatomy of the breast as well as the areas of breast including the tail of spans. We proceed to the female breast anatomy. The structure of the female breast is complex, including fat, glandular, and connective tissue, as well as lobes, lobules, ducts, lymph nodes, blood vessels, and ligaments. Here on the right side corner of this PowerPoint, you can see the photos of each mentioned parts. First one is the lobules and ducts. Each breast has a number of sections, or lobules, that branch out from the nipple. Each lobule holds tiny, hollow sacs, or the alveoli. The lobules are linked by a network of thin tubes or ducts. If you're breastfeeding, ducts carry milk from the alveoli toward the dark area of skin in the center of the breast or the areola. From the areola, the ducts join together into larger ducts ending at the nipple. Second one is the fat, ligaments, and connective tissue. Spaces around the lobules and ducts are filled with fat, ligaments, and connective tissues. The amount of fat in your breasts largely determines their size. The actual milk producing structures are nearly the same in all women. Female breast tissue is sensitive to cyclic changes in hormone levels. Most women's breast tissue changes as they age, with more fat relative to the amount of dense tissue. Third is the muscles. The breast has no muscle tissue. Muscles lie underneath the breasts, however, separating them from your ribs. Now, for the fourth one is the arteries and capillaries. Oxygen and nutrients travel to breast tissue through the blood in your arteries and capillaries that are thin, fragile blood vessels. Lastly, the lymph nodes and lymph ducts. The lymphatic system is a network of lymph nodes and lymph ducts that helps fight infection. Lymph nodes found under the armpit, above the collarbone, behind the breastbone, and in other parts of the body trap harmful substances that might be in the lymphatic system and safely drain them from the body. Now, how do breasts work? Female hormones, namely estrogen, progesterone, and prolactin, play a key role in breast development and function. First one is the estrogen. It stretches milk ducts and helps them create side branches to carry more milk. Prolactin, which promotes the production of progesterone and prepares glands for milk production. And lastly, the progesterone increases the number and size of lobules in preparation for the breastfeeding. This hormone also enlarges blood vessels and breast cells after ovulation. You may experience swollen, tender breasts. Of course, there is a male breast anatomy. Males have breasts too. During puberty, the male hormone testosterone usually stops breasts from developing like a female's. On the outside, males have nipples and areolae. Internally, they have undeveloped milk ducts and no glandular tissue. Male breast problems can include gynecomastia, a benign condition that causes the breasts to enlarge, and very rarely breast cancer. Breasts in men and women have the same origin and development until puberty. They originate from the fourth pair of lactiferous points. Development starts during the fourth week of gestation with the growth of a basic milk streak. Milk lines, or the ventral epidermal ridges, are seen by the sixth week of the embryo's life. Glands and their ducts develop separately. The development progresses in women, whereas in men, the progress stops. Some people have several pairs of breast germs within the milk lines, although not all of them develop completely after birth. The nipple and areola in men are small in size. The nipples are located on the midclavicular lines. Their heights are 2 to 5 millimeters. The lobules and ducts are short and not developed. The size and shape of the breasts are variable and depend on the age, development of subcutaneous fat, and constitutional features. The nipple is located in the center of the breast and consists of muscular and epithelial tissues. It is surrounded by the areola, a pigmented skin area with multiple sweat glands. The breast is bordered by the anterior and posterior leaf of the superficial fascia of the thorax. Adipose tissue can be observed as subcutaneous fat and fatty lobes, which are surrounded with connective tissue fibers. The breast capsule is formed by connective tissue and fixed to the pectoral fascia. The breast is highly vascular and is supplied by the branches of the internal thoracic, subclavian, axillary, and intercostal arteries that form the rete of anastomosis, predominantly in the subareolar area. The venous rete accompanies the corresponding arteries and arterioles. We proceed to the pathophysiology of breast carcinoma or cancer. There we point first some of the clinical signs and symptoms that exist for breast cancer. Here in this table you can see the signs and symptoms column, and the other one is the characteristics. Below that are two classifications, which are benign or not becoming cancerous, and malignant, tending to infiltrate, metastasize, and terminate fatally. In the case of our patient, she has breast carcinoma stage 4 that has metastasized to her pulmonary area. First one is the breast mass. It is the dominant mass, that is a distinct mass that is asymmetric with the other breast. Benign findings are often associated with cysts, fibroadenomas, or fibrocystic changes. Malignant disease often has abnormal cell proliferation and calcifications, manifesting as a fixed, firm mass with irregular borders, and a suspicious dominant mass should undergo diagnostic tests. For the benign ones, there will be absence of discrete lump. It is mobile, soft, smooth borders, and tender, meaning sensitive to touch. Unlike in malignant, there will be discrete lump, fixed, firm, irregular borders, and non-tender. Second one is nipple discharge. It is usually benign, but discharge with blood from a single duct or associated with breast mass raises probability of cancer. For the benign, the color is milky, green, or yellow, and it it deals with multiple ducts and produced with manual expression. In malignant, They are bloody or serous, single duct, and produced spontaneously. Now, for the third one is the mastalgia or breast pain. It is rarely the presenting symptom of breast cancer. The cyclic mastalgia, it is the hormonal changes during the menstrual cycle that trigger an increase in the breast size and volume. For the benign, it is bilateral, it is diffuse, it is worse during the late luteal phase of menstrual cycle and subsides with onset of menstruation. Now, for the malignant, it is focal, or you observe that the pain is always in that certain part of your breast. Fourth one is shortness of breath or dyspnea, and for the characteristics, both of them would explain metastatic disease to the lungs. Fifth, bone pain and symptoms of hypercalcemia. Also, bone metastasis. Next one is abdominal distension and jaundice, or the yellowing of the skin. This means that the liver and peritoneal metastasis. And lastly, altered cognitive function and local neurological signs. Therefore, it means that it has metastasized to the brain. Let's take a look at the diagram of the pathophysiology of breast cancer. When there's cell death, there's cell replacement that will trigger response with the carcinogen. The arrows pointing to this box are the predisposing factors and precipitating factors. The conditions that bring about susceptibility of a person to these are the gender and sometimes age and genetic or hereditary. It is more likely that this type of disease affects women than men, and that if you have a family history of breast cancer and genetic factors, especially if it's first degree relatives of patients with breast cancer, have a twofold to a threefold excess risk for developing the disease. In the case of our group's patient, she is a woman at the age of 59. For the precipitating factors, it can be because of lifestyle, sexual practice, acquiring of any type of virus, environmental factors, chemical and physical factors. Therefore, with this response, it may damage or change in genetic material or DNA. Breast cancers develop due to DNA damage and genetic mutations that can be influenced by exposure to estrogen. Sometimes there will be an inheritance of DNA defects or pro-cancerous genes like the BRCA1 or the breast cancer 1 and BRCA2 or the breast cancer 2. Thus, the family history of ovarian or breast cancer increases the risk for breast cancer development. In a normal individual, the immune system attacks cells with abnormal DNA or abnormal growth. This fails in those with breast cancer disease, leading to tumor growth and spread. With this, an abnormal or unusual increase in the elements composing a part of the cell with change of DNA happens, that is, hyperplasia. Now, what happens is that the injury will be returning or happening time after time until metaplasia happens, or it is the abnormal replacement of breast cancer cells of one type by cells of another, or transformation of one tissue into another. This time, there will be prolonged injury to the cells or tissues until mutation happens and there will be loss of P53 or TP53, which is a rare breast cancer cause and causes Li-Fraumeni syndrome. Next to that would have to be loss of apoptosis. There is a normal physiological process eliminating DNA damaged, superfluous, or unwanted cells, since there is no more self-activation of either by presence of a stimulus or removal of a suppressing agent or stimulus, dysplasia and anaplasia occur. Abnormal cells start to grow and develop so as the reversion of cells to a more undifferentiated form. Expected that since they rule the body, there will be decreased T cells, specifically the cytotoxic T cells that specialized in killing infected cells, and helper T cells that recruit other cells to fight the invaders. The possible cause of this would have to be it will absorb surrounding nutrients, causing cell starvation. The hypothalamus, vital for autonomic regulation, will involve in the hydrolysis of fat or splitting it, causing fat loss, weakness, weight loss, anorexia, and the known wasting syndrome or cachexia. This is a general physical wasting and malnutrition usually associated with chronic disease. The effect of this can be the formation of tumors or neoplasia and later on promotion of cancer. A tumor or cancer cell that has grown 1 centimeter, formation and differentiation of blood vessels, also known as angiogenesis growth factor, causing a part or parts of the breast or breasts to have lumps, also in the tail of Spence, mentioned a while ago in the discussion of anatomy and physiology of the breast. A rash or skin that's thick, red, or dimple like an orange peel would be visible to the breasts called the pudorunge, and nipple inversion or nipples that are flat or pointing inward. The symptoms and state the breast has to undergo would cause deficiency of oxygen or hypoxia, lactic acid. It is a hygroscopic organic acid present normally especially in muscle tissue as a product of anaerobic glycolysis produced in carbohydrate matter, and later on causing pain. Managements are needed to be carried out to alleviate this condition. If the size of a tumor has grown bigger, anoxia and cell death would expectedly happen. This anoxia is a severe type of hypoxia that results permanent damage to the cells. Inflammation would occur, therefore it would be painful, and the substance pyrogen that's a fever producing would result to recurrent fever. That's it for the pathophysiology of breast cancer diagram. Now, since our case patient has a stage 4 breast cancer that has metastasized to her lungs, I present to you some of the clinical findings of invasive breast cancer that our patient has. Credits to the owner. So here you can see invasive breast cancer. So it will cause malignant cells that are rapidly dividing. So first, the cells packed in a confined space in parts of the breast like the duct or lobule, and it will cause a highly dense nodule feels firm during palpation. Therefore, it would cause firm, ill-defined breast nodule. Next to that would cause malignant cells to migrate from site of origin. So I have mentioned before the locations or areas of the breast where malignant cells are found. So it gives original clump of the cells an irregular border, therefore making it spiculated appearance on the mammogram. Spiculated meaning it is a slender pointed appearance on the mammogram. Invasive breast cancer would result tumor invasion of first Cooper's ligaments. These are the ligaments that create and support normal breast morphology, and the Cooper's ligaments retract in response to tumor infiltration, pulling the skin of the breast inwards, causing skin dimpling. Skin dimpling is just exhibiting or forming dimples. Tumor invasion of lactiferous ducts under the nipple. First, the tumor infiltration can shorten ducts, pulling the nipple into the areola, causing nipple retraction or inversion new onset. Also, enhancement of ductal secretions, causing nipple discharge, usually unilateral, spontaneous, and uniductal. We also have here the mechanism, the pectoralis and or intercostal muscles, where tumor adheres to chest wall, causing immobile nodules, and the skin of the breast causes the tumor to outgrow its blood supply, causing skin ulceration or necrosis. Invasive breast cancer would also cause tumor cells in breast's dermal layer release inflammatory cytokines. Cytokines cause local vasodilation of blood vessels under the skin, causing more blood to enter the skin of the breast, making it appear red, which means a diffused breast erythema or redness. And lastly, we have here tumor cells infiltrate lymphatic ducts, draining breast tissue, would cause obstruction of lymphatic drainage of interstitial fluid, and where a fluid accumulates under the skin of the breast, causing edema. It will again cause this texture or orange peel appearance called the pudorunge texture. So with these symptoms or with these signs or love finding diffuse breast erythema and pudorunge texture, it would actually complicate to inflammatory breast cancer, almost 1% of all invasive cancers. During the late stage, the spread of tumor cells throughout the breast activate local nociceptors. When we say nociceptor, it is a receptors in the skin for nociceptive stimuli or a pain sense organ, causing our breast or a patient with breast cancer to have a painful breast. Now that's all for the breast cancer clinical findings. Let's hear the next presenter. Thank you.